This is Charles Denham, Chairman of TMIT, and it's a great pleasure to welcome those of you that are on our webinar today. We are really privileged to have an absolutely terrific team today. The title is Off the Wall, Save Lives by Putting Your Values to Work. And we're really honored to have an absolutely terrific group coming. I'd just like to, as your host, have you just make sure that you have the volume turned up on your computer. We frequently have folks that are anxious because they can't hear, and please make sure that you are, I'm on slide 3, addressing the issue regarding the webinar sound, and make sure that you have your volume up, and that if you're still having difficulty, that you could request a phone line and then access the webinar by a direct phone line. You'll see on slide 4 that we are you can go through our website to have access to the content, the audio recording, the slides, and a transcript. And we have the lovely picture of Ann Rhoades, who is the star of our show today, and her new book, Built on Values. And you see that up in the upcoming events section of the webinar. Now, when you click on that section, or in future, our webinar section, you'll be able to download the audio file, and within 3 business days, have a word searchable document if you'd like to go back to hear what Ann has said and grab a quote, or you'd like to hear what our distinguished panel has said. And you can click, and I'm on the next slide, you can click on the webinar links. Now, for those of you that have not downloaded the slides or not on the webinar and only on an audio portion for whatever reason, you may go to our website and click on our webinar links to be able to access that. We have on our slide number 7 our disclosure statement of the companies that those of us have worked for and work with, and we'd like to add also GE is one of the companies who's now going to sponsor our next documentary that we will be undertaking, and this will be part of the slide set. You know, it's my great pleasure to go to our first panelist who, as those of you that are on our webinars know, we always want to start a webinar with a voice of the patient or families that we serve and end with that. This is not tokenism. This is to really set our minds and our hearts to be receptive to what we're hearing, especially when we're focused on leadership. And what we'd like to do is turn to Regina Holliday, who is a patient safety advocate, somebody who I would put in the same category with Ann Rhoades and my wife Betsy, what I would call a force of good nature. I met Regina as a speaker in Washington, D.C. as we were speaking to 1,000 hospital quality improvement organization leaders at what you would think would be a fuddy-duddy sort of government meeting. And Regina told such a compelling story of her husband's odyssey and how she has testified to Congress and been a champion across the nation for patients and advocates using her skills as an artist and the gifts of communication that she has as a former theater major. And she had a standing ovation from 1,000 leaders in an audience at a government meeting, which I've never seen before. Regina, would you open us with and set our minds straight as we start down this path of the webinar focused on leadership?
Thank you so much, Chuck. This is just amazing to be part of this process and to be with such great leaders, and to be there as a patient and caregiver representative. One of the reasons that I went into this was because after 11 weeks of hospitalization in 5 facilities with my husband's kidney cancer, I saw so many problems within the systems. And that's what I've worked for ever since, is to create actually systems change, to change cultures. And a lot of the ways we do that is from above, talking to leaders about how they're advocating for patients and families, how they're guiding us and setting us in the right direction. And this is just a beautiful opportunity to get everybody together and come up with some wonderful plans of how we're going to make patient care better for everyone.
Thank you, Reggie. And you can go on safetyleaders.org to hear Reggie tell her story. We've got a short video clip called Remember the Holidays in honor of her husband. I'm just going to go through a very quick set of slides that we have at the beginning of our session and give the majority of the time to Ann Rhoades, but just address that our mission is to save lives, save money, and build value in the communities we serve. I'm on slide 11. The focus of our work is tied to the National Quality Forum Safe Practices. Ann Rhoades was a contributor and instrumental in helping us develop the leadership practice number 1, as well as our workforce practices. And the future programs that you'll see, including our Green Light program, I'm on the slide that says Green Light program, really provides a bit of an introduction to Charles Barnett, the CEO of Seton Medical Center, his CFO, Doug Waite, and the Chief Quality and Safety Officer for Seton, Dr. Frank Mazza, a dear friend who I've actually practiced medicine with and for both of our former lives. And they're part of the Green Light program, which you see before you, which you can go on our website to learn more about. And Ann Rhoades was also instrumental in helping us craft the leadership focus of that initiative. We just want to remind people that the Hospital Leaders Toolbox, Chasing Zero, it is now being released, and Ann Rhoades and a number of the folks you'll hear in our webinars will be in that, and we address the leadership issues of awareness, accountability, ability, and action. And I'm, again, breezing through these slides to give all of the time to Ann, but the Leadership Toolbox will also have Ann Rhoades quotes as well as sections, and we'll keep updating those. Also, Ann has been quoted in numerous times in our articles in the Journal for Patient Safety. I'm now the editor-in-chief, and we're asking for more leadership articles from people like CEOs and like leadership experts such as Ann. We also want to remind you that we're on Facebook and using social media to leverage these messages. And then finally, the new documentary that we're shooting now called Out of the Danger Zone. Ann Rhoades, Charles Barnett, Seton Medical Center, who you'll hear about as we listen to this group, will all be in this new Discovery Channel documentary, which will be released later this year. So I'd like to turn things over to Ann Rhoades, an absolute powerhouse. She has an MBA. She's an international people systems expert. We've co-developed a company called Care Leaders Corporation to test these values, and they're already in the values method that is currently in 18 hospitals in 3 states. Ann has been the Vice President of People Systems Department or People Department for Southwest Airlines. She's been an Executive VP and done transformational work in the hotel industry. Most recently, she has been a co-founder of JetBlue Airways, and we all know what a great experience that they tried to create. She's on numerous boards and now is just releasing her new book, which she will share with us. And we've had just a wonderful experience seeing her kind of leadership in action, and we turn to her as one of the leaders in the world in leadership, specifically focused on people systems. Ann, please take it away.
Hello, everyone. It's great to be here. I have to tell you, about 7 years ago when Chuck and I started on this journey in healthcare, I had a lot to learn, and since then I've learned that some of my favorite people are actually on this line and in healthcare and doing what you do every day. It's been a pleasure to get to work in the hospitals and in some of the other areas that we've worked in healthcare, and I just want to begin by thanking you all for what you do every single day for my family and so many other people. I'm going to talk today about a model on building an organization around values, and I would bet that probably most of you have some values defined. And hopefully you'll learn something today that we've learned and that I can pass on how you make sure that those organizations that are built on values actually live and breathe the values and behave in a way that emulates those values every day. And this model has been built over the years of seeing values-based organizations and the things they did right to make sure that, all of us that love values-based organizations forget sometimes that it takes work. It doesn't just keep happening. We can define these values and define the organizations and build it, but we have to keep maintaining it. It's like anything else that's worth something, we maintain it. And there's a methodology for that in the system. We work with Heritage Home Healthcare is one of the groups we worked with in home healthcare, and I think one of the things that I wanted to begin with was a statement that Len made to me the other day, and he said that creating and running a values-based organization is important because our values define who we are, what we believe, how we act, how we treat each other, and how we treat our patients and clients. It is the only thing in an organization that is really important because the rest will take care of itself. He's a true values-led leader, and he has a values-based organization, and he lives and breathes it, and he makes his decisions around those values and those behaviors every day. I saw him last night, and he gave me all kinds of new ideas, which I get all the time from some of the best players in healthcare. I want to just outline a basic values model that we talk about in the book, but that we've learned a lot from in terms of healthcare. One of the things is that you have to blueprint who you want to be. You don't just put the values on the wall, and so many times that happens in organizations, but we don't build a blueprint behind it, which is really a definition of what we mean. It defines the behaviors, and it defines how people will be expected to and held accountable for in terms of behaviors in an organization. Again, it's very different because many organizations just plaster the values on the wall and walk away. And when we were at Loma Linda, for instance, they had those values. They're a 100-year-old organization, and they're a wonderful model. And what they had said, and what Ruthita Fikes said, who was the CEO, is we have values on the wall, but I'm not sure they're still consistent with our mission today because they were defined many, many years ago. And secondly, I'm not sure anyone knows particularly what they mean in terms of behaviors. So I'll show you a model and what they came up with in terms of their behaviors, and now the accountability model they have, and some other examples of other healthcare groups. The other thing they did was they wanted to define a system for hiring A players. So many times we go into healthcare and we hear from nurses and from other people within the healthcare environment that they don't have a real system for hiring people. Many, many years ago, I started believing in a behavioral hiring model, which is a very specific hiring model that was used in the military starting in World War II. And it defined what an A player looked like in terms of a pilot. And how they defined it was they took the pilots that were hitting the targets during the war and found out that they behaved consistently in a similar manner. And they use that as their model for A players on a go-forward basis. We've taken that model to healthcare, and we've defined and have actually 54 positions in healthcare that we've looked at, and we found out that there's a consistency of behaviors in the A players in those positions. And we've defined that model and now built a hiring model around it to show you, and the book talks about it, and to show you how to hire people consistent with the values and the behaviors you want to see in each position. Accountability rewards, to me, nothing is worth it unless we hold people accountable, and it won't really happen unless we do that, and also reward them for the right behaviors. Not reward them for time and job, but for the right behaviors. And then I believe we can brand that model around the values for our patients. Critically important, we'll show you some examples of how people are doing that. And at the end of the day, it's about discipline. It's about quality and safety and making sure that we get better at that. It's so critical in healthcare, and it's been something that we talk about, but having a system behind it is so critical instead of just talking about it. And Chuck is the father of all of those systems. I've learned a lot from him. I always kid. I say, what's your worst dream? I've worked with pilots all my life. Now it's a doc who is also a pilot. It's a stitch. We're having a great time. So the first thing I'd like to talk to you about is a values blueprint. Again, values on the wall don't just make it happen. You have to actually define what you want. So we say that you craft a real values blueprint. And it really does take time and effort, but not as much as you think. Typically in the healthcare environments, it took us about 2 days of sitting in a room. And what we say is that you put the people in the room that are literally all engaged in the organization in making it happen for the patients and the families. And one of the things you do is you literally get people from all areas of the organization. At Loma Linda, we had people that were brand new to Loma Linda. We had people that had been there many, many years. We had people from each of the practices. We had physicians. We had patients. And we sat in a room for a day and a half, and we took the values they had on the wall and started defining behaviors around those. After we vetted the values and made sure they were ones that were still consistent with the mission again, we found out that they wanted to add a couple values, and for the most part, they retained the values they had, like caring and passion and those things that they had for many years, but they wanted to add a couple values that they felt would be part of the new mission and where they wanted to go. Rosita was very clear about it when she stood up, the CEO, and talked about what she had in terms of a vision for their model. So we sat for a day and a half in a room, and we actually worked out the values and the behaviors, reconfirmed the values and worked out the behaviors. And then we published what we called a first draft. And then what we did was we took it out to all of the hospitals and the different practices around the hospital and the different administrative areas, and made sure that the people that are part of the system also felt that that was a good definition, and that in fact it was a great time to reinforce the values by going over them. We published the first draft. The executive team looked at it, said yes, it was something they that was clear, made it clearer to them, and it was something they wanted to do. We actually went through a very systematic process of talking about an implementation plan and timeline, which we tell everyone to do. It really is about a system. This isn't soft. This isn't something you can't measure. We also put measures in there, just like you're used to, measures that would show that it was, in fact, making a difference. This is a picture of one of the workouts in one of our favorite hospitals, and it has people from, again, all the areas talking about who do we want to be and how do we want to define the behaviors. This is the result at Loma Linda. This is actually a copy of their mission statement, their vision statement, and then the values. But what's been added here are the specific behaviors behind each value. Compassion, integrity, excellence, teamwork, and wholeness are the values. And then they have a very short definition of those. And behind that, they have 5 minimum behaviors that everyone will be held accountable for that reflect those values. It made such a difference. For instance, one of the first areas we went into was to look at the jobs in the transporting area. And what made a difference was for the transporters, you and I may have our own definition of integrity, but for transporters who were new to that job, and for the most part had not been in healthcare before, they wanted a definition around their behaviors. And so we defined those behaviors and started holding them accountable, and the results I'll show you in a minute. But that was the start of making sure that everyone was paying attention to and being held accountable. And by the way, I would just want to say one thing. This also is reflective of Safe Practice 1 and the NQF standards. If you look at it, it says to confirm your values. Confirmation of values is one of the safe practices. And governance leaders, it says, should regularly confirm with the senior team that you are ensuring that the values of the organization are being lived and that they're being mirrored in the behaviors of the organization. And they suggest doing it at least annually. And I know in other organizations we do that, and now they're doing that at Loma Linda, though I believe they're doing it more than annually. And in the other organizations we've been in, they said that they do it fairly frequently, and I believe common to do it quarterly. And I would suggest that you do that. It just keeps it in the forefront, and it keeps it in the front of your mind when you're making the tough decisions. You know, values and behaviors are easy when you don't have to make the tough decisions. When people really know you're running a values organization is when you make the tough decisions using the values. And to me, that's a sign of a great organization, a great hospital. This is a values communication plan that I referred to earlier on. It's a systematic day with the dates, with the venues, with the target audience, with those people responsible, what the specific messages will be, and what the aids and tools are that you need to carry out this vision and the value message. And they look and feel differently, but this is just a sample. We have many more samples. Most importantly is, of course, once you've defined the values, you can hire people to those values and behaviors. People believe that it is all about competencies and all about attributes when you go to hire someone. So they look at people and look at their star players, but they forget to look at and make sure that they not only hire for those competencies and those attributes that they have shown to be, that the A players reflect, but they need to also hire people that reflect their values. In addition to the other things that we look at, I will tell you it makes a huge difference in how well your team works. It makes a huge difference in the quality of player that you get. When you hire people with integrity, when that's one of your values, it makes an immense difference in the type of, and also people typically that with integrity want to play with people and work with people that have integrity. This is Loma Linda's model. They actually called it soaring. And Dr. Winslow, who was the head of culture and took on this job of driving the values to the organization and the accountability and the entire model, he literally came up with this acronym, and I love it. And it's soaring, and it includes a selection around the values, orientation. Their whole orientation program, by the way, which I don't talk about later, but is outstanding. The first day you come to work there, they actually talk about the values all day and walk through the organization and show them the values in action. They don't sit in a room and fill out the paperwork. They've decided that is a useless day, and that doesn't impact players the first day like they wanted to, so that they know what the expectation is. So they literally have them walk through the organization and see the values in action. Then they appraise people and hold them accountable for the values and the behaviors, and then they recognize those, and I'll show you some of those samples. One of the things I like to impress upon people is that values hiring is really a strategic business responsibility. It's really not something that's soft and not something that you can't measure. It is all about being strategic and about hiring the right people to take care of your patients and the families. Safe Practice 9, if you look at it under Nursing Workforce, also talks about values-grounded behavioral-based interviewing methods, and that they will help you optimize the selection of new staff. It's something we don't think about, but every place we've put it in, we have seen a significant decrease in the turnover numbers in every single case. And in addition, we're getting feedback now saying that the performance levels, when they have done their annual performance reviews, have really increased. And I'll give you some other samples in a minute. Accountability and rewards. It's all about accountability at the end of the day and rewarding the right behaviors, and we forget that sometimes. And it doesn't have to be expensive. Southwest, for instance, where I grew up, we literally gave no monetary rewards, but we recognized people for the right behaviors, and that's why 35,000 people today and just under 2,000 flights a day behave the same way when you experience that behavior. It's because they're held accountable for their behaviors. Values recognition program at Loma Linda, I love. They have done a great job of it. They actually have recognition from an institutional standpoint where the leaders recognize people. They have department recognition. They have administrator to employee recognition. They have employee to employee, patient to employee, leadership peer recognition, and team to team. I cannot tell you and be strong enough about my belief that it is all about rewarding the right behaviors and saying thank you. And I know how swamped you are, and I know how busy and how overwhelmed we are given all the things we have to do in healthcare today, but I can tell you it is worth every minute you spend recognizing people. They will not forget it, and it reinforces the behavior so that they behave that way again. And it shows the others in the organization what is being rewarded, and it's really important. This is their values manager's kit, and it has sheets of paper. If you look at the white under what looks like a bracelet, but it's actually a key ring, every time you show one of the values, you will get a value to put on a key ring. And people, he said, have actually made those values into bracelets at Loma Linda, that they value them so much. They have little cards where a manager can walk the hall and see someone showing the value of integrity, and they fill out the card on the back and thank them. The CD, Living Our Values, went to their homes with a bag of popcorn, and it was showing people example after example of people living the value in the organization. I believe at the end of the day you can use your values to brand the patient experience. This is one of the ways that they tell their love stories in Living Our Values at Loma Linda. It's in the lobbies, and people can read example after example of many of their players living the values and the kind of behaviors they can expect at the hospital. At the end of the day, and there are many more examples of that, at the end of the day it's also about continuous discipline, and it's about getting better and having better quality scores and being safer hospital. And I will tell you that there is such a model, and Jerry says that when he put this model in and when they put in all the numbers, do you know that the people at Loma Linda actually know the numbers? They know the number of patients that are expected. They know the number. They have numbers that they have that are their very generic metrics, and in each area they set metrics so that everyone can, on quality and safety, so everyone has a goal. And it doesn't matter if they're a transporter. It doesn't matter where they fall within the organization. It is all about continuous improvement and getting better at what they do. He told me to tell you that he was so excited because he thinks that at the end of the day, I asked for his comment on putting this model in place and being very specific about it and being very driven about it being a system. And he said, I think we wanted to move from good to great, Ann, and that's why we did it. I talked to him yesterday, and he said he wanted me to tell everyone never in their history have they had a 99% positive customer sat score until they had a new hospital that they put in place, and they used this model from scratch. And he said, we didn't even believe it. We ran the score twice because we couldn't believe it. But we didn't allow people to move to the hospital until they had gone through the hiring model around the values and the competencies, even if they were in the system. And they decided to play a very hard line on that because they wanted to show that this model worked even from scratch. And they just came up with 99. And as I said, they didn't believe it, so they ran it again and got 99 again. It's just a simple, and I make it sound so simple, and there's lots more detail in the book and lots more detail Chuck can give you and Care Leader's website can give you. But it is about consistency. Like everything else we do, it's a science. And I believe it's about a science, the science of great quality and great safety driven by great people in great organizations. It's all about what we believe. But it gives you a system to do that around the people side. We have so much science that we use in our practice, but the people side is not always something we have a science around. I think one of my favorite quotes is what Chuck said. He said, if every story has a hero, a villain, a victim and a villain, a crisis and a resolution, we want you to see yourself as a hero. It is time to write your own story. Turn that light into heat and focus it on your villain, the villain that protects the status quo, the way we have always done things. Thank you all for listening. If you have any questions, I'd be glad to answer them at a later date.
So, Ann, thank you very much. Ann has really kept us on time, so we have abundant opportunity for Q&A. And and I guess it's that aviation thing, Ann, that gets you done right on time. And before I introduce our panel, I just make a comment is that I heard Ann speak at a national meeting of the CEOs for 1,700 hospitals, I guess 7 years ago. And when Ann gave her speech along with two other noteworthy national speakers, it was the first time in 10 years with this particular group that I had ever seen these CEOs take a pen out of their pocket and start writing things down. And it was shocking. And then there were a breakout session, and the breakout session, we gave the opportunity for these 250 CEOs that represented many hospital systems to then move out into the breakout sessions, and the majority went to Ann, and I think the other two speakers probably could have gone for coffee because nobody showed up at their breakouts. And when I asked those CEOs why, it was because Ann took something warm and fuzzy and soft and systematized it. And the specifics, I think that, and I wrote it in an article, Ann, and cited you, in Values Genetics, who are the smartest guys in the room, and wrote it for doctors to say, if a value was a gene and a trait was the behavior that is exhibited by that value that's a gene, that's how you end up with the culture. And I'll never forget when shooting a video with Ann, we were talking about how do we communicate this concept to our leaders, and the dialogue resulted in a great quote that the leaders drive values, values drive behaviors, and the collective behaviors of the organization are its culture that deliver against performance. And we've said it many different ways, Ann, but I think that the systematic approach you used at JetBlue and Southwest was so powerful to me that we thought, could this work in hospitals? And Ann has talked about Loma Linda, but we're seeing it at Florida Hospital and a whole host of other hospitals. So, Ann, we want to thank you for taking a chance on us in healthcare to see if you could bring this Southwest, JetBlue, and kind of this Ann Rhoades model to us. I'd like to just turn to each one of our panelists. And so we'll start with our three reaction panel from Seton Medical Center, starting with Dr. Frank Mazza, then Doug Waite, their CFO, and the anchor man will be our CEO, Representative Charles Barnett. And then what I'd like to do is I'll turn to Tom VanderWaal, and Tom will be kind of representing boards, and he's the recently retired board chair of the Virginia Mason, one of our just outstanding hospitals that was named Hospital of the Decade by the Leapfrog Group. And Tom has joined us to help us with our board work, and then back to Regina. So I'd like to start off by inviting Dr. Frank Mazza to speak first. Dr. Mazza is an MD. He was trained at the University of Pittsburgh School of Medicine. He specialized in pulmonary and critical care, and I have to tell you that I worked with Frank for a number of years in Austin, Texas. I subspecialized in lung cancer and worked with Frank and other leading pulmonologists, but he was an absolute delight to work with, a superstar physician that all of us as physicians thought were just like our number one guy we'd send our wife or our mom or our brother or sister to, and now we see him at just an all-star cast at Seton Medical Center doing the same thing, which is really a great servant leader and doing great work at Seton Medical Center. So Frank, could you react to what you heard from Ann and then apply it to the Seton story?
Well, I sure can, Chuck, but you know, I hope that neither Ann nor the rest of the folks who are on the call would mind if, in view of the fact that you've mentioned that both of us used to be in private practice a number of years ago and that we worked together, if I could take the time to brag on you for a moment, because I know that you're too modest to do so. For the group on the phone, as Chuck mentioned, he and I worked together starting back in the mid to late 1980s. And besides being a very smart, very compassionate fellow as a lung cancer radiation oncologist, he really brought with him a lot of new technologies that we had never seen before in the Austin medical community. And in fact, some of them he invented. And even after he left, we are still using those technologies to the benefit of all the people in Central Texas here. And we owe a debt of gratitude to him. But I think even more important than his contributions here, the reason he left is because he really recognized a long time ago, and long before I think just about anyone else in the world did, the value of clinical quality and patient safety and what it means to patients as a whole. And I think right now we're all benefiting, Chuck, from your vision and your dedication and your capabilities. So thank you for all you've done, obviously, for patient safety around the room. Well, I greatly appreciate the comments that Ann has made today, and I've also enjoyed reading her book. First, because I think she's dead on her thinking, and second, because I think her model is yet one more validation for us in terms of the direction we've taken as a values-driven organization here at Seton. You know, there's just so much I can comment on, but I think that what I'm going to speak to is that here at Seton, we genuinely believe that patient safety is one of our core values. And for us to be successful in empowering our associates and giving them the permission that they need to lead our efforts to be ultra-safe and to be patient-centered, we need to, and I believe we do hold them in the highest regard, and we do recognize them as our biggest assets. And I think that this is an organization that I believe looks for and seeks out the A players in a lot of things that we do. In terms of them as our biggest asset, we also, I think, try to demonstrate our commitment by treating associate safety with every bit the same importance that we do patient safety. And we also try to do this through our model community efforts. The Seton Family Hospitals is part of the National Ascension Health System, and Ascension believes in having a model community of inspired people. And I believe we really take to heart the need to give voice to our associates in the same way we want to give voice to our patients. And for that matter, it also holds true for some of our other efforts, such as the relationship-based care model that our nurses have been rolling out and our patient safety initiative. So I guess in summary, what I would say is that just like I think Ann believes, we believe that our associates are fundamental to the success of really all of our efforts. And all of those that I've just mentioned really highlight some variation of our desire to be ultra-safe, patient-centered, and highly reliable in the care we deliver.
Well, thank you, Frank, and you also demonstrate being a great communicator. I think these initiatives, we want to make sure that people are aware of the powerful impact that Ascension has had, and we've written about it in numerous articles, and want to remind everyone that the Journal for Patient Safety has allowed us to give those articles away if we reference the National Quality Forum of Safe Practices. And the Ascension story is actually in the article that Dennis Quaid is the lead author on, Story Power, the Secret Weapon. And Ann is also, I believe, cited in that as well. One of the great strengths that we saw in establishing our Greenlight program and inviting certain leaders from around the country to meet with the agency leaders, I can't telegraph it, but I can hint at the fact that we probably will see in the next 3 weeks some announcements coming from the Centers for Medicare and Medicaid. They're going to focus on the areas where they expect dramatic improvement, and that dramatic improvement will be in areas of patient safety and quality. I don't think I'm telling anything out of school. We know lots of detail. We know that this is going to be an exciting thing that CMS will do. We know this because of public meetings that have been undertaken with the quality improvement organizations. And we also know that it's absolutely critical that our financial officers and those leaders in our organizations that are in charge of resources, CFOs and COOs, are absolutely critical. We had a meeting in the National Press Club in Washington and invited Charles Barnett, who you'll hear speak in just a few moments, as well as Tom VanderWaal. But we invited Doug Waite. He was the only CFO, actually, that we invited. And he did a terrific job of expressing the heartfelt importance that CFOs believe that we have in having to focus on patient safety. And he was a great representative of that profession, and really, I think, showed the entire group at the meeting, as he related, a personal story, that our CFOs are really receptive to hearing from us, and they really need to be on these meetings and these teams. And it's not just all about the numbers. And I was so impressed with Doug, and I'd heard about him from Dr. Mazza and from the Austin community. So we're really honored to have Doug express his views and reaction in the Seton story as well. But he's, I think, the role model of our future CFOs.
Well, thank you, Chuck. I really appreciate those comments. That means a lot to me coming from you. I think, as Ann points out in her book, that we need to be able, as individual leaders, to be able to demonstrate and kind of walk the talk, if you will, about our personal values. And for me, one of the really, I think, changed the type of CFO that I ultimately have become was when I was a brand new CFO. My daughter was born and ended up spending 5 months in a neonatal unit. And we fortunately had a good outcome, and she got married this summer and is doing wonderfully. But it changed the kind of CFO I am today, because I spent all of that time in a concentrated way on, if you will, the other side of the business that I'm in, meaning the clinical side. And so I think that kind of changed my perspective on many of these activities that we're doing, because, as you said, Chuck, that we need to be able to make this just convert it from a warm and fuzzy kind of a perspective on the part of CFOs to something that is to help them see that this can really help improve financial performance. And I think Ann points that out in her book repeatedly. And that because I think CFOs sometimes will shy away from what might be perceived in a stereotypical sort of way, the warm and fuzzy, and might steer away from that. And we need to be able to get them involved and be able to spend some time on the other side of the business, because I think if we all do that, and then the clinical folks try to understand the business side of it together, we can achieve some pretty powerful accomplishments. I think, as Ann pointed out too, was one of the turnover concerns that we have in healthcare. And I know when I've done skip level sessions with my frontline staff across Seton, that one of the things I consistently hear, based on the values of our organization and of Ascension Health, that's one of the things that they like about working at Seton, and that is the mission, the values, and the people that they get to work with. And I think we enjoy a lot of A players, as Ann describes them, and I think because of those, that helps us reduce what will otherwise be a much higher rate of turnover. I think the other point is that that Ann pointed out too is when you get into some metrics and scorecards, that keeping it simple helps CFOs understand and stay focused as well. And I really appreciated her comments in that regard too. And I think as CFOs, if we can work together with the clinical folks and vice versa, that together we can continue to achieve very powerful activities. I think another thing is when you have to make tough decisions, having a strong value base can make some of those tough decisions easier. And there are instances, in my experience as a CFO, where I could fall back on the values and the mission of the organization, and that helps drive your decision and makes it a little easier than if you didn't have those. And I can vouch for that personally in many cases, including sometimes when you have to, when we've had to reduce staff, and if they know that our values are going to be for helping them find new jobs, get retraining, education assistance, and that sort of thing, that they know they're going to be able to stick with you because your values will help them end up landing on their feet, if you will, in spite of some tough decisions that have to be made. So with all of that, I'll turn it back to you, Chuck, and be glad to answer any questions later.
Great. Thank you very much, Doug. And I'd like to remind the audience we're seeing some comments that are in the Q&A window, but I think the expression of appreciation of the time that you all are spending with us and the quality is there. I've had a question regarding whether there will be a recording of this webinar, and in fact there will be a recording of the webinar. We will convert it into a transcript that will be word searchable so you can go back to quotes, and the audio will be tied to the slides, because I think you're getting the reaction panel to Ann and to the panel to recognition of the quality of your comments and how important. I think we have to stop the hamster wheel for a moment and just listen to our colleagues, and nothing more important, I think, than with great CEOs like Charles Barnett, who I had the chance to spend time with at the National Press Club meeting, where we did assemble about 35 leaders. We had CEOs from the Partners System in Boston, a good friend and colleague, Gary Gottlieb, as well as leaders from Cleveland Clinic, Mayo Clinic, some of the Harvard hospital leadership staff. We had Vanderbilt Medical Center. We had Rathita Fike, who Ann had referred to. I must say that Charles' comments in the formal session were powerful. They spoke to the issue of values. They spoke to the kind of leader he is, and they really resonated with what we've been hearing through the community in Austin, Texas, where our headquarters is, as well as the colleagues across the system in Ascension. However, when we got him in front of the camera for our Discovery Channel movie, we were actually just shocked and amazed at how articulate he was, and almost every take that we got, he gave us a bit of a dilemma in that we don't know which one to pick for our Discovery Channel movie, but most assuredly the Seton story, and Charles Barnett will be in it. He is the CEO of Ascension Health. I'd rather have him kind of speak to the issue of the footprint of Seton, because we haven't covered that yet. He has an esteemed history of successes, and I would say that as I talk to people across the country, Seton is one of the ministries of Ascension that really is a place where you can go and see the values transmitted. And Charles, I want to thank you also for taking good care of our employees, because a number of our employees at our headquarters go to Seton, receive care there, and a lot of my old doc colleagues speak very highly of your leadership there. So, Charles, would you maybe give us just the quick footprint of the Seton system, and then also react to Ann and apply that to the Seton story, and maybe your message, to other CEOs about the lessons that can be learned about values, behaviors, and performance.
Chuck, I'd be happy to do that, and I also would like to thank you for assembling the kind of talent that you assembled in Washington at the Press Club. I consider it a privilege to be able to be there, and as in the really good meetings that I get to attend, I learn things that are very valuable as we think about how we're going to have to transform the delivery system in our local communities, in the states where we serve communities, and throughout the United States. So thanks for your leadership. Let me start by saying, giving you some background on the Seton family of hospitals, which represents 10 hospitals in Central Texas, covering about 1.7 million individuals across 11 counties, with a very broad range of services, including a university medical center, the Dell Children's Medical Center, which is a tertiary and quaternary children's hospital, as well as a very large referral hospital where our heart transplants are done, and a broad range of hospitals from suburban to rural critical access hospitals. We also provide a number of other services, like providing all of the student health service nurses for the Austin Independent School District. So we have a large range of community service that we deliver within Central Texas. Seton is part of Ascension Health. I serve as the ministry market leader for Texas and now for Missouri and our hospitals in Kansas City. As Chuck had mentioned that I was the CEO of Ascension, Tony Tersini, who is the CEO, if he's on this web seminar, must be looking at his name tag to see who is actually the CEO. I thought Ann's presentation was very helpful, and what I would say is we are the beneficiaries of a tradition which reaches back almost 400 years, in which mission and values have been important to the kind of community service and care that have been delivered by the Vincentian family, including the Daughters of Charity. And as I was listening to Ann talk about the importance of being able to operationalize both the mission and the values, it reminded me of the exercise that we had to go through in the very early stages of putting this very large system together, as healthcare organizations that did not have a tradition of being within the Catholic health ministry came into the Seton family, and we really had to change the way we talked about our mission and our values, although we didn't change the fundamental components that made up that mission and those values. But we did need to make them accessible to all of our associates. We have about 11,600 associates within the Seton family. We needed to make them relevant for our associates, and we needed to make sure that they were useful in providing guidance for our associates as they thought about their behavior relating one to another, relating to our physician community, and providing service to our patients. And it became a sort of a true north for us as we engaged in the patient safety activities, because one of our statements in our mission is that we believe that all persons by their creation are endowed with dignity. And in our values, we use the concept of reverence, respect and compassion for the dignity and diversity of life. And as we thought about the questions that we were considering regarding a completely safe clinical environment, I spent the morning having breakfast with Ken Shine, who was the head of the Institute of Medicine when To Err Is Human was published. And we were talking about how important it is to understand that a safe clinical experience for a patient is one of the best ways to demonstrate the respect for the dignity of that person and their loved ones. And it became easy for us to think about how the effort that we needed to engage in to change the way we operated, to change the the way that care was delivered within the Seton family of hospitals as well as within Ascension Health, because this was a national initiative, how that was a manifestation of our mission with regard to dignity as well as our values. And it became easier for our associates, our physician partners, I think, to make the connections between what we were all doing collectively to try to accomplish some of the really remarkable things that have been done, such as the perinatal safety initiatives, which have resulted in the lowest birth trauma rate in the United States. So I can't say enough about how important it is to have your associates aligned with you as leaders in organizations, your physicians aligned with the organization around mission and values, and using the guidance that provides to be able to help us understand that it is like a needle on a compass. It creates the direction that we will need to continue to pursue.
Well, thank you, Charles, so much. And we've covered the high level, the Q&A. We're going to get into some really tough questions that we can throw at our panel and Ann. And you've really intimated as to how, one can use the values as a compass and, in fact, a litmus test. And we'll have some questions for Ann to kind of come back to as we loop through this. Kyle, if you would either give me control or go to slide 30, please, as I introduce Tom VanderWaal. Tom is an absolutely terrific guy, and again, I'm just overwhelmed by the talent we have on this call. Tom, a former maritime CEO that made safety part of his the intrinsic property, and I won't steal his thunder. I'd like to have him share with you briefly, his the roles and laughingly that we call his series of failed retirements. He's a former CEO and leader of 2 maritime companies, one a shipyard, but importantly, he's told us many stories about how safety was an intrinsic property of one of his maritime companies, and stories of how they've applied some of the best practices that we need to. His real terrific expertise, although very gifted guy, is in the area of governance, in the area of how do we work as boards of directors with our C-suite, with the CEO, CFO, the chief quality officers, and then down at the line, and how do we, in effect, create a high-performance boardroom, meaning that the decisions that the board make 9 to 13 times a year, and Ann Rhoades is on the board of a number of public companies and is well thought of and highly pursued to be such, but make those board governance decisions with the C-suite, team with the C-suite, and then actually get those core values to translate down to the front line. And we're honored to announce that Tom will be joining us at TMIT and leading an effort called Care Boards, where we're going to undertake a high-performance board approach to assemble the world's best practices, concepts, tools, and resources that then will allow us to really take the interaction with our board at the C-suite and down at the ground level with our caregivers and actually make that happen. Now, Ann was instrumental in helping us write the SAFE practice for the National Quality Forum SAFE practices. However, we used model hospitals as examples to write the practice when we updated it in 2006, updated it in 2009 and 2010, and we used Virginia Mason Hospital as one of the shining stars of terrific board governance. I actually spent the first time with Tom when we interviewed him, and as the chairman of the Leapfrog Safe Practices program, Tom was the representative, and he's a humble representative, always giving credit to his board and the team and Gary Kaplan, the CEO, but he was the representative of Virginia Mason winning the Leapfrog Award for Governance that Leapfrog gave, and we videotaped him, and I was so impressed with his ability to communicate and translate a lot of these complex issues down to really good common sense about governance, and he's opened our eyes. I think he's opened our eyes to what governance best practices, and we've tried to open his eyes as to the challenges frontline hospitals have that may not have the kind of talent that Virginia Mason had grown up. And Tom was the chairman of the board of Virginia Mason, as well as a board member, and was, I believe, an instrumental player on that board team that crafted the strategic plan that ultimately ended up with Virginia Mason winning the Hospital of the Decade Award that we also filmed for our Discovery movie at the Leapfrog Group in the first week of December. Tom, would you please give us a quick snapshot of how you'd applied core values to safety and quality, and then what's important about the boards and what you heard from Ann, and then we'll move to Reggie, and then we'll open it up to Ann, answer a bunch of questions, and solve all our problems for us.
Thank you, Chuck. And Ann, great work on the book. I really loved it. Great blueprint in terms of how we move culture forward in the organization. And I would like to zero in and support your recognition of the importance of the board and the C-suite. And to follow on Chuck's comments, I like to think of that in terms of a boardroom, i.e. the C-suite can't move forward on something as important as culture alone without the board, and certainly the board can't move forward without the C-suite. So I like to think of it in terms of the boardroom. Traditionally, board members, the CEO, and add to that the C-suite, the patient safety officer, the Safety and Quality Committee reporting routinely in the boardroom, patient telling their stories in the boardroom, and caregivers telling their stories in the boardroom. I think the more we think about the boardroom, that's where the power really lies to move forward on patient safety. Second point I'd like to make is on safe practice number 1, where we are to create and sustain a healthcare culture of safety. And it's almost like there's a word missing there, and Ann, you certainly picked up on it. We can't just create and expect culture to stick and just automatically move to sustainment. We at Virginia Mason back in 2003 undertook to enhance our strategic plan and our cultural values at the same time. We worked hard at all aspects of that. We thought we communicated it well. We really zeroed in on transparency. And we had just put in place a patient safety alert system, which asked and supported everybody in the organization to raise their hand when they saw an unsafe event likely to occur or that had occurred. And we were only receiving about 50 patient safety alerts a month, and we knew it was just the tip of the iceberg. In 2004, we experienced a tragic preventable death of Mary McClinton in the hospital, and many of you have heard that story. I'd been on the board for some time, had just assumed the chair responsibility. And Gary and I got together and we said we need a all-hands meeting to discuss culture and safety and quality in the organization. We put the meeting together. Gary discussed the operational responsibilities, what we were doing operationally to prevent accidents like this from occurring in the future. And on behalf of the board, the majority of the board members were with us in this particular meeting. I spoke to the ultimate responsibility of the board to patient safety in the organization, in that we owned the systems. And as we all know, 90% of patient safety hazards and incidents are system related. We spoke for about an hour, and what we found out was that the board had been heard to support transparency and a culture of safety, but had been heard in terms of memos. The board had not really been seen to support patient safety and a culture of transparency. And Gary and I have been told many times after that particular discussion that it was really a transformational event in the organization. The board had not come forward and been seen to support the culture of safety and transparency. The board and the CEO had not been seen together to support a safety culture. We had been receiving, as I noted, about 50 patient safety alerts a month. A month after our discussion, we were up to 150 patient safety alerts. And in 2 months, we were up to 350 patient safety alerts a month. And as you all know, learning from our mistakes and or near misses is so important. So what we learned as a board was that we need to be thinking in terms of the boardroom, just the board. CEO and the C-suite can't do it alone, board can't do it alone. And the board needs to be seen and to see what's going on in the organization. You can learn a lot from the culture of safety survey that we all undertake, but you can learn a tremendous amount more by going out and putting a face on the statistics that you see in the organization. Round with the staff. Go into the nurses' stations. Spend some time with them at lunch breaks. Ask questions. How are we doing? What can we do to help? Bring the patient into the boardroom. Ask the same of the patient. How are we doing? How can we do better? In that same process, then the board will also be seen. It'll be seen in terms of being engaged alongside the CEO. It'll be seen in terms of participating in performance improvement workshops. And it'll be seen with the CEO so that we don't have silos of governance responsibility and C-suite responsibility. Teamwork is as important or more important between the board and the C-suite than it is when we get out into the caregiver environment. It has to start at the boardroom. So our learnings were very, very powerful, and we've translated that into a number of different practices and procedures. But my message would be we have to get the boardroom involved, and there are people on the board just like ourselves. They want to do right for the patient. They don't always know exactly what to do. So invite your board member to come on a rounding trip with you. Invite your board member to some of the employee events that take place. Include them in performance improvement initiatives. All that will gel the boardroom together, and that is where the power lays to really make a difference.
Great. Well, thank you so much, Tom. And I just got an email from Frank. I just wanted to see, because Charles Barnett will have to get off the call right now, before we go to Regina, and then we'll go to Ann for Q&A with Ann and her comments. Charles, do you have any other comments that you would like to address before you have to jump off? And I understand that Frank and Doug will be able to stay on. Charles?
Yeah, Chuck, thanks. I need to go to a board, committee meeting on our physician relationships. But I think the comments that have just been made about governance are really critical, that we really have to engage lay board members in the kind of dialogue around what does the organization stand for, and that gets reflected in the organization's articulated mission and values, and then it gets manifested in the behavior. And I do think, having chaired healthcare organization boards as well as serving in the CEO role, that it's a powerful force for ensuring that you've got those both values and mission as central to what the organization thinks about when it makes choices. And it chooses what it's going to really apply itself to accomplish. So I think that, again, Ann's comments were very helpful. I thought the book is really very insightful, and appreciate the opportunity to have been able to be part of this, the webcast. So, Chuck, and thanks again for the leadership that you provide.
Well, thanks a lot, Charles, and we really appreciate you pulling so many of your team members out. But I think it speaks volumes that a CFO, a CEO, a Chief Quality and Safety Officer are this aligned and on the same call. So we really want to thank you for that. We're at 5 minutes after the hour, and we're going to extend the webinar. I'm getting great emails from people that are loving what they're hearing. Yes, the webinar will be recorded, including the Q&A and the comments from the reactor panels, and we'll extend the webinar. If Ann can stay with us for an extra 10 minutes at the end, just so that we give her ample time for Q&A because we're running just a little bit late. So we'll turn to Reggie. Reggie, can you give us your 3-minute sort of reaction to what you're hearing, and then we'll go to Ann for Q&A and responses from the rest of the team, and Reggie will also have you close at the very end. But if you could stay with us also to a little extra 10 minutes at the end. We're getting rave reviews from emails that I'm getting coming in, and we'd like to extend if we can. So, Reggie, your short comments, and then we'll go to Ann and open up for Q&A.
Well, this is really amazing. Ann had some spectacular things to say today, as well as the rest of the panel. And as a visual artist, as well as advocate, a lot of those words would just pop out. And about what culture means based on actually appreciating it and doing something with it versus just writing it on the wall. And one of the things that just kept popping out was the board and how it works with the C-suite. And the visualization I had in my mind was, well, the board itself and a board. And think about that. When we think about boards, sometimes we think about like walking the plank, you know, the fear factor. And a lot of people in organizations, they're doing things because they're fearful. They're fearful they'll lose their job. They'll feel fearful that if they make waves that they could get in trouble. And then I want you to think about diving off the diving board and what that is. That's about having bravery, being willing to join the crowd, trying something even if it's hard to do. And a lot of what Ann's talking about in this book to me seems like embracing that diving board, being willing as a board and as a C-suite to go out there and be a leader that creates respect and joy among the people working within the organization. And that is a lot of what I feel within this call, and I think the direction that the organization is wanting to go in, because that creates ownership with every member of the team. And then leadership can start at all levels of the organization, opposed to being just something that's considered part of boardroom behavior. So I have found that people have had to say incredibly exciting today on this call. So
Reggie, we're going to have to commission you to do the painting of 2 diving boards, right? One walking the plank and then the other one doing a full gainer, and we've got to figure out how Tom VanderWaal is going to help us figure out how to not swim with the sharks. So
that is correct.
We're going to go a little bit longer because I'm just getting rave reviews. Yes, it will be recorded for those that do not are logging on late. Ann, you have such a wonderful voice. You've listened to the reaction panel reacting to you. Can you help us with the challenges of a culture in a hospital where the behaviors are not mirroring the values? What can we do? What can we do if we're at a hospital that is purely performance or financially driven, where employees feel kind of trapped in that organization? What can we as individuals in that system do? How do we deal with that, and what can we do, Ann?
Well, one thing that we can do is obviously in our own departments, in our own areas, make sure that that's not true. When we're in control as leaders of at least our own area, we can actually build a model that maybe the rest of the hospital can see is effective, is productive, is frankly delivers on the mission and the vision, and behaves in a way that is reflective of the values. You can actually build it within your own area, and I've had people stop me after giving speeches telling me in their own hospital environments they have done that. And while maybe some areas did not reflect it in the other parts of the organization, they were very proud of what they had built. So that's one thing you can do. The other thing is you can help influence those people that run that organization to start making the right decisions, and to not have people represent them that don't, in fact, reflect those values. And in one case, it was actually a cardiologist in a Florida hospital we were working with was not reflecting the values, and he was causing a number of people who did live the values to leave that department. The organization was very concerned about losing him because he filled the operating rooms. we ended up discussing it. They did not allow him to practice any longer in that hospital. They did not renew his right to practice. And they said today the rooms are filled, and people have come back that were A players in that area because they wanted to work in that hospital, but they wanted to work in an environment that lived and breathed the values. So there are a number of ways you can do it, but what I would tell you to do is to take the time to think it through, but to take action. This doesn't happen unless you are brave. What we were just talking about, and what I thought was great about what Regina said, is this isn't for the light of heart. This isn't for people who aren't values-driven. It's no longer a time to sit back and take it. It's a time to be very active in telling people what you think and standing up for what you know is right.
And the second question revolves around engaging doctors. Doctors come from a highly disciplined area where there's much to analytics, and actually we as physicians are trained to divorce ourselves from the emotional side. Dan Heath and Chip Heath, who wrote the recent book Switch, talk about the rider, the elephant, and the path, and that we need to really inform the rider, which is our conscious mind, but it's really the elephant, which is our passion, our heart, which is the emotions of fear, passion, dread, hope, joy, and that you really need to appeal to both to be able to change and move down a new path that you have to design that's easy for the elephant to kind of follow. But doctors are not typically thought of as being very emotional creatures and having to divorce themselves from this, especially to focus on this soft and fuzzy stuff that a lot of them would say was just malarkey. Are you surprised? I am actually surprised being with you in multiple workout sessions with doctors and how they embraced it and kind of completely went with the program of trying to create a blueprint and taking something seems like soft value stuff and turn it into explicit behaviors. Are you surprised, or do you see this all the time?
I'm very happy, and I always believed they were that way anyway, so I'm very happy to see that. You know what it is really, at the end of the day, if you think about it this way, many people are in it for what's in it for me. So as a practitioner and a clinician, if you show a physician who is in the same practice in many ways, if you show him or he or she, what is in it for them? In other words, how are you going to improve the quality and safety? There's not a physician I've ever met that does not care about that. And they don't care about being really, really good at what they do. And if you show them why doing these things will help them and make them better, I think then we can sell it in a way that everyone buys into it. Jerry Winslow called me yesterday from Loma Linda. It was really interesting. He said, everything you've told me worked. He said, I have to tell you, when we showed the physicians this, they were skeptical. He said they came back 3 months later and said, oh, by the way, we want the hiring model. He said, then they came back, and he said, now we are teaching them how to put this model into their practices. He said, that's when I knew we won Ann, but they had to see why it worked and how it helped make them better. And so I would just tell you from my learnings, and I'm not an expert at this because I haven't been in your field as long as most of you all have, but what I've heard is that people do want to be better at what they do, and if you show them how this makes them better, tell me, Chuck, as a physician, I think that's what you want.
So I'm going to turn to Frank and then to Doug and say, if you had to write a one-pager reader's guide to Ann's book for the people you deal with, so I'm asking you, Frank, for doctors and clinical people and administrators you deal with in safety and quality, and you had to write a review of Ann's book and describe what the value is or what to really look for in it for engaging doctors and getting them in the game in patient safety. And I'm going to ask the same thing of Doug for CFOs. If you wrote a reader's guide, one-pager on Ann's book, what is it that a doctor or a clinical person or chief nursing officer or leader of a clinical division, what would they get out of that book? Because you took the time to read it.
Well, I would say that I think Ann basically nailed it with her last comments. I think that all people in healthcare, and certainly physicians as well, want to do the right thing. And I think if you can make the case to them, the business case or really the practitioner case, that doing the right thing in terms of having the commitments, being agreeable to be accountable for what you're doing, accepting that you have a leadership role, wanting to be the best possible person that you could do. This is the book that will give you all the tools you need to do that. I just basically think that she's really right on the money in terms of all the things that she mentions in the book that would help us to do that.
Well, thanks. As I turn to Doug, I recently finished a call with, I think, one of the really unsung champions and heroes in the national scene is Chris Azui at Blue Cross Blue Shield in Chicago, who is tireless at looking for opportunities to really get those that are paying for health care to recognize patient safety opportunities and tie the finance piece back to the values and under the leadership of Alan Korn, another great champion for patient safety who has a great voice for it as well. They try to tie things to the financial piece. As we look at from a CFO or a purchaser's perspective, you wrote a one-page kind of, here's the reader's guide to a CFO of Ann's book. Are there things that you would uniquely want to pick out of it that had some, actionable information?
Yeah, I think there's two primary things I would point to. One is, as Ann pointed out in her presentation today, is the blueprint and working through the whole process of if an organization has not already done that, is to go through and follow that blueprint and all the way, the full circle that she outlined, because I think that would help them determine how to get to that point, because then a byproduct from that is improved financial performance from a CFO perspective. You'll get better, I think, clinical performance and financial performance. I think the other part of it is that there's some real specific examples in here, which I think a lot of CFOs like, that Ann pointed to. Yes, they may be in the airline industry or the hotel industry, but nevertheless, I think there's a lot of learnings that we could get from other industries and apply to healthcare. And I think that the real life examples that she pointed to, I think, are testimony to what can be done.
Thanks. I reflect, Ann and I are collaborating with a fellow named Bob Chapman, who is the CEO of a company called Barry Waymiller, 49 acquisitions, extraordinary performance, year over year, 20% growth. And they buy manufacturing companies with broken cultures, and they turn them around, and interviewing and talking with their staff and seeing how Bob and his team have put the core values of fulfillment of the employee first, knowing that everything else is going to come into alignment, and coupling it with the Toyota Lean model, and so having a fulfillment-driven value set that then are tied to Lean, and then a good financial model. They've had just extraordinary performance, but it really was the leadership from the top. So as I turn now to Tom, asking him the same question, but now as a governance expert, looking at developing best practices for boards. You're writing the Leader's Guide to Ann's book for governance leaders. Let's talk about the freshman non-clinical board member and the freshman clinical board member, but they're both freshmen to the board, like a great guy like David Parda from West Penn Allegheny Health System, who's a great clinical. For those two people, because you know both, Tom, what do we take away from Ann's book as a board member, and also with your intimate knowledge of the NQFSA practices and what we're driving with SP1, what would you say?
Well, I think the blueprint, build on values model, works extremely well for the boardroom. And again, the boardroom needs to lead the way and walk the talk if they expect the rest of the organization to follow. The boardroom ought to be deeply involved in either enhancing or renewing the value blueprint, if you will. We need to be selecting board members who also subscribe to the values that the organization has adopted. We do that on the management side. We need to be selecting board members with the same overall discipline. Accountability and reward. We need to, in the evaluation criteria for the boardroom and for individual board members, Those evaluations need to look at whether the individual member and the board as a whole is walking the talk on accountability. We need to focus on the patient and continuous discipline. We need to continually be out and about to determine whether the organization as a whole has a continuous discipline with respect to the cultural values that have been built as a result of the values blueprint. If it doesn't happen in the boardroom and people don't see it happen in the boardroom, it's not going to occur in the rest of the organization.
That's great, Tom. So, and just so everybody knows, Tom will be one of the experts on our webinar we'll be hosting for Medicare for the leaders of all the QIOs in 50 states and 3 territories. And the charge is to address how do you approach the board from the outside. If you were a QIO or a performance improvement group, or even, let's say, you want to approach your own board, you know, as Regina said, you know, it's kind of like, it feels like it's a Shark Tank and you're going in to walk the plank, and you know, there's a, you know, could get hurt going in. You don't even know how to, you know, approach that hot potato. So Tom will look forward to that webinar, and you know, in February. Jennifer Hollenbach, Ann, is one of our attendees of the webinar, and she states that personal values and beliefs, you know, may not be in an organization, and you don't know. And let's say you're going to apply to a new organization, you want to go and get a job there. How can you tell they've got a great culture when you're interviewing for a new position, and you want to know whether they really live and breathe the culture and the values are in effect off the wall and being lived? You know, as you look for a new place to go and work, how do you assess an organization as it relates to values?
Well, it's a reverse interview. So you ask questions around their values, you ask questions around the behaviors, but I don't ever go work in an organization without walking the halls. I always go meet the leaders and then walk and make sure that I do it usually on my time when they don't know I'm there. I go in and walk and talk to the people that are there. If you have a chance to talk to people that have been patients, I would talk to them and find out what the real experiences of people that work inside and the patients then, and also the family members. The more due diligence you can do to find out about the values and about who they really are, the better your decision will be.
Great. Ann, you've heard a lot here. You want to kind of tell us, what are the FAQs that you get about core values that we should know about in healthcare? You know, what are give us the questions and the answers to the 3 top questions that we ask you in healthcare.
Which top questions?
So you're frequently asked about people because you speak at healthcare organizations. What are the most common questions that you're asked about values, value blueprinting, and that kind of thing, and then what are your answers? What does everybody else want to know? Maybe we're not asking all the right questions. What are the questions that you think we should be asking or you're being asked, and then what are your answers?
I'm very often asked, how do I get the Chief Financial Officer to really believe that what I want to do in terms of quality and safety that we can actually afford to do? I thought Doug's comments were particularly important in that if they understand that good CFOs understand the ROI when it's not always as clear in the way that some of them think. But I think that it's critical that you have a partnership, and they always ask me, how do I get a partnership with the finance area? How do I make them understand how important this is to quality and safety, and how at the end of the day we can show a great ROI on quality and safety? I get asked that almost all the time. And where I don't get asked it is where I meet people like Doug describes and like I know he is from his answers, where the Chief Financial Officer, and I would tell you we need more of these people, Chief Financial Officer understands the ROI when it comes to quality and safety. And I get asked that question all the time.
So let me interrupt you real quick before your next question and come back to Doug, because we rarely get such a great role model on a webinar. Doug, any tips on how our webinar attendees could approach or think about approaching their CFO regarding safety and quality? What tips might you add? And then, Ann, we'll come back to your next question that you're frequently asked. But Doug, what are the tips you could give us to approach our CFOs?
it's kind of give the CFO an assurance that, it's, I hesitate to say a guarantee because there's bound to be exceptions to that rule, but to be able to say to them, that you're going to do this and it's going to improve financial performance. And you can't, I think also, because we've had experience with this where we had, as Charles alluded to early on, where with newborn trauma, well, that cost us money because we had fewer injured babies go into our neonatal unit. Well, but it was the right thing to do, from a personal value standpoint, a community value standpoint, it was the right thing to do. But there are many other things that will more than offset that loss that we had. Early on, earlier in my career, we started taking a look at repeat X-rays. Well, that we weren't going to get paid for, by many payers, and yet by having to repeat them, you're exposing the patient to more radiation, so you can improve safety if you can do it right the first time, and therefore, so you can reduce your costs because you're not having to repeat that X-ray. So that's a simple example, but I think if you can really get in and do the right analysis and partner with them, I think eventually they'll begin to see it.
I think an example is the Green Light program that you're a part of, that when we really show side by side, here's an event, here's not an event, and we take all the complexity out, side by side twin analysis without all the complexity. I think we feel like we've then simplified the issue and given a CFO the floor of the benefit, not the whole picture, and exaggerated the numbers. Let's go back to Ann. Ann, what's another common question that you get, and what's the answer?
How do I get my leader to know that he or she has to live and breathe the values if they're going to expect us to? It's consistent in hospitals to hear that the leaders are not living and breathing those values, and I would just send the message to leaders that it starts with you and ends with you. So you don't get to have a bad day. You don't get to have integrity one day and not have it some other day, because then they'll never believe you have it. So you have to live and breathe those values if you're going to put them on a wall. And the first people you should hold accountable are yourself. So I tell people to go back and to, when they have an opportunity, to revisit those behaviors with those leaders in the room and to ask them for examples and to reinforce the need for everyone to be living and breathing those values. It doesn't always work, but I have seen it at least in one case recently where it did change the behavior of a CEO to have that conversation around it in a management meeting.
And one thing that, there are a few things in my life as a doctor that I go back to that have been transformational. One of them as a radiation oncologist was understanding the super high power that you can have by using radioactive implants with radiation. But another one is what you taught me, which is that you can systematize and be explicit about behaviors and tie them to soft things that just sound warm and fuzzy that are values. And that's what led me to write the article, Values Genetics, and really dig into this and be your devotee, if you will, as we go back to it. And one of the things that I tell people is take the core values, read about Ann and what she says, but take the core values and then write the behaviors in your slide set at the very beginning and say, well, we at Seton or we at, XYZ General, St. Elsewhere Hospital, these are our values, and because of these values, here's what I'm proposing that we do because it ties to our values. So that every presentation you start with, you use that lens for the boss. Because what I found when I've asked people to do that, the boss starts to say, can I have those slides? So, I think you have no idea how virally you've started this sort of phenomenon, and nobody gets upset with it because it's really what the boss should be saying anyway. Instead of calling the boss out, you basically are being an example for the boss in your presentations. So, you've really had that impact. Let's go back. Is Frank still on? If Frank is still on, I'd like to come back to the engagement of physicians. And can you tell us the biggest challenges you face engaging doctors in quality and safety and how values might help you?
Well, I am still on, obviously, Chuck. And I would say that the biggest difficulty we have is not in engaging them once we hook them. It's really getting their time and attention in the first place. What we have attempted to do, and what seems to have worked pretty well from us, is First, Charles has created a very transparent organization, and so the doctors are fully apprised of everything that basically those of us who are in senior leadership are aware of, and they've been part of the team, and they're very visible on the board, and they are exposed to and see how the board and how the senior leaders live out the mission and the values that Seton expounds upon, and then we try to support them in every way in their leadership so that they in turn can really begin to understand that part of those mission and values is doing the right thing on behalf of patients, being patient-centered, wanting to give the highest quality, wanting to give the safest patient care. And again, I think that because I'm a firm believer, as Ann is, that doctors want to do the right thing, I think if you can model for them that behavior, and if you could provide a venue for them to be part of that, then they can be successful in incorporating it into their practices and modeling it for other physicians. We're going through currently a high reliability transformation, and in doing so, that's really all about behavioral change, and we're lucky enough to have our med staff buy into the fact that physician training, physician reinforcement of those behaviors is a critical aspect. So I hope that we'll be able to get to more of our med staff overall than we've been able to get to in the past, but I think I would not be telling the truth if I didn't say that in what's a pretty challenging environment for our physicians, there are some people who really have not participated as much as we'd like to see in the business of the hospital, and there's some, of course, that don't even come to the hospital anymore, that we have trouble reaching sometimes.
So, Ann, I want to come back to Tom and kind of address, this intersection at the boardroom of board action. Ann, you're a board member of public companies. You work with boards and directors of for-profit organizations, and you're also a board member and co-founder of organizations that are in the nonprofit space. Can you, Tom, maybe tee up some of your observations for the biggest challenges that boards face today in hospitals, and maybe get Ann to react to that before we go to Regina for our final comments?
Sure. I think as it relates to patient safety, the first thing that we need to convince the boards on is that ultimately they are responsible for patient safety. They have the legal and fiduciary responsibilities for safety, and they have the core governance responsibilities for safety. Number two is storytelling. I think we need to tell the stories, have them available to the boardrooms, that the boardrooms taking the lead on things such as culture, particularly culture of transparency as it relates to patient safety. Many boardrooms have already gone down that path. There are many lessons to be learned from them without reinventing the wheel, and provide the boardroom with the will and the courage to make the change because they know that others have gone before them by demonstrating how they did it and what they did and the results that came from those actions. Again, board members want to do what's right. They don't always know exactly what to do, and the more we can help them with painting the picture, providing a roadmap in terms of how they can improve patient safety in their organization through their leadership, that's how we're going to move the dial on patient safety.
Great. So what I want to do is I've saved, we're going to go 10 minutes after, but I'm going to give more generous time to Reggie because I'd like to have Reggie, after Ann comments, I have a question for her. I'd like, Reggie, for you to take a little longer than you were to close us. and give us the story that we recorded of you, of the story of your husband and the odyssey that you went through, the 4 or 5 minutes sort of, or 3 or 4 minute sort of story, because I think it's so powerful, and we don't do you justice on this webinar unless we hear it. But I'm coming back to Ann, and Ann, if I were to buy your book for every board member of my hospital and give it to the board members, what should I tell them about reading it for a retreat? What would, I'm sure this is going to happen, so I'm sure you thought about it, and if not, we will. When I buy, which I know I'm going to do, I'm going to buy your book for my local hospital board members. What do I need to tell them about reading it, and what should they discuss after?
I guess I would just say that the book is a model for building a values-based organization, but more than that, it's a model for starting with boards on how you not only build, but then how you maintain it, and it starts with their behaviors. And there are examples in the book about great organizations and how their boards have used it as a model, not when they had to make the decisions every day, because that's easy. It's when they had to make the tough decisions around the values, and that's when it was critical and when it made a world of difference. One of the players in one of the hospitals called me yesterday, or day before yesterday, and he said, you know what I know now? He said, I know it works, because he said this year we had to make some of the toughest decisions we've ever made. But I think we made them the right way, because we literally put the values before the board with the senior team when we made the decisions, and we played them by, is this decision played to the values? So I think if it does nothing else but show them a model and reiterate the importance of doing that it's probably worth revisiting.
Great. So I'm going to turn to Reggie and ask her 3 things. I'd like to have her, she's listened to all of us talk about applying these principles, and maybe be the final reactor to our reactions to Ann's book, number 1, and what she's heard from the other folks. Then number 2, Reggie, would you please tell your story, your brief story? You do it so well and so briefly, of what happened with your husband and what led you to where you are today. And then we'll just ask Reggie to close us with her recommendations or her words of wisdom. And then when she's finished, the webinar will be closed, because I think we should begin with the patient and voice of the family and end with it. I will say, as the introduction to her closing us, that when I was sitting with her across from her in that warm hotel room with the lights blazing, and we're shooting her for the Discovery Channel movie, I asked her, Reggie, how do you keep your positive energy up? And because every patient advocate that I've worked with at first uses it as a catharsis, but as time goes on, it takes them back to the harmful things that are crushing to their heart, and it really knocks them out for 2 or 3 days. It's happened with our patient caregivers like Julie Tao. It's happened with every family member we've worked with, from the astronaut Pete Conrad's wife to Sorrel King to Sue Sheridan. And she said, I ask God for help, and I say a prayer, and I'll never forget reaching over and holding your hand and saying a prayer with you, and realizing that you really have a mission here, and that you're really giving us a gift that we could never thank you enough for. Would you tell your story, and then we'll close.
Thank you, Chuck. My husband was a professor of film studies at American University. He was hired in September of 2008, and that was after adjuncting at multiple universities for years as a part-time employee. So when he got finally a full-time job, he got to get a physical and found he had hypertension. And then he was fatigued throughout the fall, but, it was a brand-new job. And then in January, he started having extreme rib pain, and he went to the doctor and the ER, and they said he had broken ribs from coughing. And he was 38 years old at the time. And so we thought that was unusual, but that's what they said, so he took pain medication. And then in February, the pain in his ribs wasn't as bad. It now was in his back. So he's having extreme lower back pain. And he went back to the doctor multiple times and kept being given pain meds. On March 13th, 2009, he was in so much pain, and it was a Friday night, that we gathered the whole family up to take to the emergency room, and waited for 3 hours in chairs for somebody to see him. Finally, somebody from Express Wound Care said, well, we can give you an x-ray, but nothing else. The MRIs are backed up, and so are the CT scans. So here's some more pain meds. You probably should go back to your doctor next week. Next week, I went back with my husband to the doctor. At this point, she said, we're concerned that maybe your husband's depressed. I said, yes, he is depressed because he's in excruciating pain all the time, and we need to determine what's wrong with him so we should get an MRI. My husband then drove himself to Olney, Maryland to get the MRI, got it on a CD, brought it to the doctor's office, left it with the doctor on a Friday. The following Tuesday, we got a phone call from her. She said that based on looking at the CD, she would like to have an appointment the next day for us with an oncologist. I wasn't really even sure what an oncologist was at that point. But I got on the internet and found out it was a cancer doctor. The next morning, my husband went to the hospital. At this point, he was in so much pain, he was admitted. 2 days later, I was working at the toy store when he called me at around 11:30 in the morning. He called crying, saying the oncologist had just been in his room and had told him he had tumors and growths throughout his abdomen and a 3-centimeter tumor in his kidney. And could I come as soon as possible because he was very worried and he didn't know what was going on. I left the toy store and I got there as fast as I could, and it took about 30 minutes. But by the time I got to the hospital, the oncologist had left for a medical conference and would be gone for the next 4 days. I went around asking the internists, the nurses, the techs, the aides, all kinds of questions, trying to figure out what was going on with my husband and how far was progressing these tumors and growths. A PET scan was done and a bone scan, and we waited quietly to hear what the results would be. 4 days later, an on-call doctor came into Fred's room, just checking on him when we asked, do you have the results of those tests? She said, you mean nobody's told you? We said, no. Oh, well, it's spread everywhere. It's in his bones and in his lungs. So that night I got on the internet and determined based on the spread of the metastases that my husband had stage 4 kidney cancer. And the likelihood of living more than 2 to 3 months was very slight. I spent the next few weeks begging for information, access to the record, a written copy. Finally, after 3 weeks, I went down to medical records and asked for an entire copy of my husband's medical record. They said it would be a 21-day wait and 73 cents per page just to have a copy of the hospital record, even though he was currently hospitalized. The very next day, the oncologist came into the room on a Saturday and said he was going to send us home on a PCA pump. I'd done my research and I knew what that meant. That meant he was going to send us home to die. We burst into tears and the doctor left the room. At that point, my husband turned to me and said, Ruthie, try to do everything you can to get me care. So I spent the next 5 days working on a transfer to another facility just so we could get a second opinion. After 5 days, we were finally transferred, but we were sent with out-of-date and incomplete medical records and transfer summaries, which meant once we got there, they could not provide care other than a hospital bed. My husband lay in his bed for 6 hours in excruciating pain while they tried to cobble together a medical record using a phone and a fax machine. The next day, the new doctors at that facility sent me back to the old facility asking me to get a copy of the entire record. I went there with the doctor's approval, and they printed the entire record out in an hour and a half. I brought it back to the new facility. They read it, and they handed it to me, saying, you should always keep this with you. If you have access to this record, your husband's going to get the best care. And I read the entire record in about 3 hours. And it was full of actionable data that if we could have only read it while these things were happening, my husband would have had better care, fewer infections, and would have had a better quality of life physically and emotionally. Having done that, we talked with each other and determined that we would do everything we could to change the system of care in hospitals so that patients weren't left out in the dark about these incredibly important decisions about their outcomes in care. And how I began doing that was painting about it. And I painted murals throughout Washington, D.C., describing our medical experience to spread awareness. So when I hear Ann speak about the writing on the wall and how that oftentimes people walk by and don't pay attention, I am amazed because I live not far away from a wall that is covered with a painting of my husband dying. And every day people walk by it, and you know what they do? They look up in shock and horror in some cases, and in other cases love. And they see it every day of their lives, and it makes them think about how we care for patients and what it means to all of us and our loved ones and our caregivers when somebody is ill. When I listen to people speak about ROI and quality and safety and where are things going with the board of directors, I want people to realize that this isn't actually a blueprint we're talking about. A blueprint is what you build a building with and then you file in a drawer and let it gather dust. This is a map, a guide, a pilot's checklist, something that must be referred to every day. And yes, when you do something daily, oftentimes it can become boring and old, and maybe we don't pay attention to it and we ignore it. But that is where patients come in. Every day we give you a brilliant gift, and that gift is a set of new eyes. I don't know if anybody's listening has ever gotten glasses. I did in 4th grade. I had gone for a year without being able to see very well. And I vividly remember the moment I first got to wear glasses because I could see trees had leaves again. Patients will give that to you. We will look around us and see everything with those beautiful new eyes. All you have to do is ask us, and all you have to do is listen to our answers. Thank you so much for what you're doing, because what you're doing not only saves lives, it mends hearts and souls.
Thank you so much, Reggie. We really, really appreciate you spending the time and putting the energy and heart. Ann, thank you for writing your book, and thank you for taking a bet on healthcare that you could have gone into any industry. And we thank God that you gave us a shot. We want to thank the Seton team for their great leadership and role modeling, and we thank Tom for dedicating the rest of his professional career to help us in hospitals and to help our governance leaders have those open eyes and see things with a new lens. This ends our webinar. We've gone a little longer, but it was worth it, and we just thank everybody for their attendance, and yes, it will be recorded and transcribed. This ends our webinar.